of the other things we know is that laws, psychology, and science have been skewed and used to justify non-equitable treatment of Black and brown bodies. So some of the more popular examples are here on the screen. They're the Tuskegee syphilis experiments, which people were really, I feel like, gaslighted and lied to, right, about treatment that they were receiving to become healthier and better and to tackle the disease that they did have. And also Henrietta Lacks, super influential, and cells are in many people who live and breathe today because of what was done with her body and her cells. And if you aren't familiar with these two examples, feel free to go ahead and do a quick Google search. There's a lot of information and media there on these folks. But we also know it didn't start here, right? We have like a history, many centuries worth of history of just mistreatment of the Black and brown body. So in the 16 and 1700s, we have chattel slavery, right? Black and brown bodies viewed mostly as property, right? We could own people, kind of like cattle, where that name comes from. In 1808, importing of Africans was banned and outlawed, but in 1865 ensued Jim Crow, right? And sharecropping, kind of like a disguised slavery or illegal slavery. As just some of the examples of like, yeah, this has been happening for a really long time, and maybe this mistrust might come from somewhere, right? I loved hearing the blurb from Cassidy about Rise this afternoon, and the work that you folks do in the space of the opioid epidemic. So we just wanted to share this quote with folks that I think really speaks to the structural factors that we'll break down later in the training. This says, systemic racism fuels the opioid crisis just as it contributes mightily to other areas of health disparities and inequity, especially for Black people. We must ensure that evidence-based interventions tailored to communities are able to cut through the economic and social factors that drive disparities in substance use and addiction to reach all people in need of services. One of the things I just thought of that I hadn't recently, but in reading this, I thought about incentivizing care, right? I know Pathways does, I think, a pretty good job at doing this for folks who have been kind of exiled from treatment spaces, right? Or told that they're not worthy or deserving of care, right? But it's like, hey, engage in this study and this treatment. Maybe you'll feel better, and also we'll give you whatever amount of money, right? There's some like maybe ethical dilemmas here, but I think they're worth talking about and worth some conversation about how we are engaging people in care and maybe what we can do to get them in the door, and then what we can do to keep them in and feel supported and do all that therapeutic fun work that contributes to their overall health and wellness. So doctors, researchers, and public health officials agree that the circumstances that put Black Americans in the crosshairs of the opioid epidemic are very complex, right? It's not just fentanyl and heroin being on the street, it's everything that makes this so accessible, or maybe more accessible, to Black and brown folks, and what happens when Black and brown folks do end up actually ingesting and using these substances on a regular basis. So a recent CDC report shows that more Black Americans died from fentanyl overdoses than from any other drug 2 years ago in 2021, and at far higher rates than white folks and Hispanic folks. So here's a little more information about how we got here, right? As a country, and service and the care that we're providing, and the folks not engaging in care right now. So the United States has had a very biased view of mental health care in general, right? But also for Black and brown folks for centuries, right? The 1840 census was the first data that ever addressed mental illness specifically in Black communities. But through a very flawed methodology, that data purported northern states, right, which during this time were the anti-slavery states, had more than 10 times the amount of mental illness, right, than the South. So they're saying, see, you guys don't want slavery, now all your people are mentally ill. This is why slavery is good, right? It's kind of used as a justification of keeping things the way they were. Another example in history that contributed to what we now call structural racism, well, yes, is the census, and we'll talk about some other spaces that this exists and break this down a little more further along in the training. But they're going to be any tool used to reinforce discriminatory beliefs, values, and distribution of resources. These ideas impact decision making and treatment regimens in the helping profession. An example here, this is a really interesting study to read about. I told Ryan I would condense this because I understand this study, but I've tried to explain it so many times and feel like I'm just fumbling over my words. But the study was done in 2016, right? So not super far away, less than a decade ago. And the outcome of the study was that there are practicing physicians, right, and residents right now practicing in the medical field who still believe and have left and graduated medical school and still like have this assumption and belief that Black people experience pain in a different way than white folks, right? For some biological reasons that we know today are not true. And what it's taken is like social workers creating spaces like this to like tell medical folks that no, Black people and white people experience pain in the same way, right? But this contributes to just the treatment that folks are receiving when we are encouraging them to seek medical treatment, right? I think one of the other things I think of to this last bullet point that says these ideas impact decision making, treatment regimens. I was talking to Ryan earlier today about Philadelphia. On Thursday, we'll be voting to ban and outlaw in our city overdose prevention centers, which is another word for safe injection sites if folks aren't familiar, right? But when we know that, okay, in 2021, more Black and brown folks died from fentanyl and opioid overdoses, and here's something that might be helpful, we're now voting to like kind of not let that happen, right? I think is another example of a very real structural barrier and speaks to the idea of structural racism.
And I just also shout out, we're going to get to a slide on like colorblindness in our system a little bit later, but if more Black folks are dying of overdose and we have this intervention to prevent overdose, then that is a disproportionate effect that is having, right? Like that would be an equitable solution to a problem that is disproportionately affecting people, and to vote no on that is an inequitable vote, right? And so we're going to make the case that is kind of a racist policy to not let that move forward. It's a complex issue. Communities are really concerned about overdoses, obviously. Communities are very concerned about places for people to inject that are considered safe. And I get that. So it's not just as simple as sort of like it is as simple as this. It is essentially a racist policy, but it's also kind of a web of things that we have to look at. But that's the case that we want to make here. That's how we got here, is things like this, decisions along the way, little by little.
Some other fun and like also disturbing examples might be like folks who like have incarceration histories not being eligible for benefits, right? Food benefits, Social Security, health benefits being taken away from them because of their incarceration history. Oh my gosh, there are so many. When folks are eligible for food stamps and food benefits, right? We can't share those benefits with our family members and community members the same way a white person might pass their debit card along to another family member of theirs who needs food and is hungry, right? We can't share that information across our communities in the same way without it being labeled a crime like welfare fraud.
So we're going to start to unpack a little bit about like how does this work? What are the pieces that sort of contribute to these disproportionate effects that we're hearing about, that we're talking about so far? We've heard a bit of the history, and I want to just put some terms down on paper with you and get on the same page about some definitions here, right? And so first we want to sort of define racism, because in the context of our training today, we're not really talking as much about kind of this like interpersonal racism that obviously exists, right? One person calling another person a name or mistreating another person because of their race. yes, that is racism, but we want to sort of take a bigger picture and understand the structural components, right? So a system of advantage based on race that is created and maintained by an interplay between psychological factors, right? These are these interpersonal things, biased thoughts, feelings, and actions, and socio-political factors, biased laws, policies, and institutions, right? Not putting in place an intervention, safe injection facilities that would disproportionately improve the lives of Black and brown individuals in our city, right? So that is a socio-political factor in that case. And then we talk so much about structural racism, institutional racism. I think it's important to like define that because anytime I've had conversations with people like sort of face to face, we use this language all the time, and I want to be really clear about what we actually mean here as we go. So it's a system in which public policies, institutional practices, cultural representations, right? Thinking about media and what we news and things like that that we consume, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. Nowhere in that definition do we see name calling, individual mistreatment, right? It's much more subtle than that. And we've been living with it, as Kalo has talked to us about the history, for over 400 years, right? And so it kind of fades into the background in terms of our day-to-day experience of how these things function and how they work, right? So structural racism really identifies kind of dimensions of our history and our culture that have allowed privileges associated with whiteness in particular, and disadvantages associated with color to endure, to adapt over time, to become more subtle, more nuanced. And so structural racism is not really something that just a few people or a few institutions practice. It's really interwoven into our society more deeply than that. Okay, so want to kind of pull people in a little bit. Talk to me a little bit about when somebody says the word racism to you, what words come to mind? Throw out kind of your like free associate a little bit in the chat. What comes to mind as you hear the word racism? Yeah, I'm seeing ignorance. I like it. Structural. Rachel is thinking structural already with that. Great. I love that. Hate. Absolutely. Injustice. Exclusion. I love the word exclusion there because sometimes that process of exclusion, we frame it as like protection, safety for me, but exclusion for you, right? That kind of thing. Intolerance, injustice, fear, inequality, stereotyping, stereotypical perspective. I like that. Yeah. Barriers, bigotry, bias. Ooh, Madison mentions 2020. I wonder if you're referencing specifically like the George Floyd uprising and how some of the racial tension in our country came to a head. Nothing new there, right? And nothing resolved since then, but definitely came to a boiling point at that point. Lack of understanding, assumptions, justification. Ooh, I like Anna's comments here. Comfort in tradition/pattern, right? It's just the way we've been doing it. And that feels comfortable because it's always how it's been. Interesting. Uneducated, protection of privilege. Yeah, sometimes even state protection of privilege. Power, deep-rooted teachings. Yes, there's so much. Otherness, us versus them. Yeah, we have a slide specifically on this. Okay, great. Thank you for just like free associating a bit. You've said a bunch of the words that we're going to say later on in this trading, so I love that. I'll note from my perspective, I think racism is a really kind of complex set of factors that are interwoven together. And so for me, I think about it as sort of bricks in a wall that end up being a barrier to health and opportunity for folks. So I think about the minority stress model, which Kalo is going to talk us through. I think about the social determinants of health. I also think about systemic versus institutional racism. Implicit came up just a second ago there from Allie. Implicit bias is a big one for me that plays a role. Microaggressions happen in day-to-day interactions, and then simply the role of stigma. So racism really blocks access to needed supports. It impacts people's pathways into homelessness and presents barriers to exiting homelessness, right? Which is what makes people difficult to engage, right? There's all these barriers to exiting homelessness. And in talking about this with Kalo earlier, the kind of thing that we wanted to weave into the training today is that maybe the question is not why is this person difficult to engage, but maybe it's why would this person engage given all the stuff that sort of is present in the background of their life, either individually or as sort of a larger generational whole that we want to paint the picture of today. So I'll leave you on this slide with that question, and I'll turn it over to Khalil to talk us through the social determinants of health.
Alrighty, so these are a list of like the major kind of components of the social determinants of health that folks might have seen in other trainings or other spaces, maybe in your education. And I think what's really interesting about this is like the social determinants of health in and of themselves are not bad things, right? Economic stability, what is that? Health and healthcare, these are all just like heavy hitting items that impact, right, the health and wellness or overall well-being of the folks that we're serving. And we usually only talk about them in a negative light because that is the context that we are working in, right? So when we're talking about economic stability, we're talking about how financial resources or lack thereof impact somebody's health. These include things like socioeconomic status, income, cost of living. This looks at how poverty, employment, food security, and housing stability affect individual health. When I think about food security, I think what's most prominent in my mind is Chester is a neighborhood here in like it borders the Philadelphia area. It's pretty close to Delaware. But Chester, for the past 12 years, has been their residents have been trying to get a grocery store in their neighborhood. This was essentially a food desert for 37,000 poor folks living in this area with no access to a grocery store. You know what Chester did have? A huge soccer stadium, right? And sports events, bringing a whole bunch of people to this neighborhood to park in their yards and block the streets. When there was soccer games going on in the area. And I think that also speaks to things like the built environment here, right? What is just physically in my space that makes life a little more challenging, right? Do I have access to public transportation if I need it? Do I have family members or social supports who are able to assist in with transportation if I need that? We're all probably likely familiar with some significant education barriers too, right? With I just watched Little Fires Everywhere for the first time. If folks are familiar, there's a huge like affirmative action kind of conversation in that show, right? And it's so wild because that show came out like I don't know how many years ago, and I'm not going to guess, but not recently, right? But more recently, there's been like no affirmative action anymore, right? That's been the conversation how this isn't fair and the idea of just policy and legislation that is supposed to like contribute to things like affirmative action being helpful and healthy for these communities are now being like kind of flipped around and saying like, well, this is racist to white folks, right? Well, what is that? That's a training and a conversation for another day. But it's just an example of the many barriers that are making things that should be solutions much harder to push forward and actually successful in bringing folks up and meeting their needs. We know, and we talked about some of the health and healthcare barriers already. There is a lot of fear for historically marginalized community in just receiving medical care and what that looks like. So getting medical care and medical coverage and health insurance is one barrier, right? But once we do that, are we getting our folks into seeing providers that care and have concern for their identities and who they are, right? Either as substance users, as queer folks, as Black and brown folks, are they being affirmed here? And they're going to want to come back, right? Ryan started with a great question of it's not like why aren't they engaging in care, but why should they? What makes that person want to go back to the doctor's office to address this this nasty wound they have on their arm, right? If they weren't treated very well and like felt that stigma and shame in that space during their last appointment. Yeah, that's a social determinants of health.
I want to add just like a really quick thing that I thought of as you were talking, Khalil. Health and healthcare and like the relationship with the built environment there also includes sort of like you go to a wealthy neighborhood, the hospital center, the clinic or whatever that's there is really nice, has the best technology. You go to a poor neighborhood, you're lucky if you're getting good care, even if the doctors are trying their best, even if the healthcare workers are like going all out to provide as good of care as they can. The sort of built environment component of that, and like what and the resources they have access to, is very different in neighborhoods like that. I think a great example of this is the Lincoln Hospital in the Bronx back in the 70s. It was called, they were calling it, I think, the meat factory or something like that. Like people were going there and dying, right? It was just like, was not a good hospital. And I'm just adding this bit in because I think it's so cool. A group of folks who were previously a gang got political, called the Young Lords. They paired up with the Black Panthers and literally took over the Lincoln Hospital to force them to make some changes and to force them to fund their communities. What they cared about was the health of their communities, and they were not seeing health and the social determinants of health supporting their overall well-being. And so they did something about it by literally taking over this hospital. And some years later, eventually they were able to push for a new hospital being built. So an example of the ways that communities recognize this themselves, right? If I live in a poor community or a segregated community, it's very clear to me that like my hospital is not as good as your hospital, right? And so I think we're talking about this stuff. Yeah, exactly. The Young Lords, Madison. There are some great documentaries out there about the Young Lords. I really encourage people to check it out.
Yeah.
Yeah, I'll stop
I
talking now.
think I think one of the other fascinating things about that hospital takeover specifically is one of the documentaries I watched about it. Ryan and I, like at work, we did this. Um, they were very proud of the idea of sharing, and like wanting people to know, like they didn't hurt anybody in the process of doing this. Nobody died in this hospital takeover. In fact, there were many medical professionals who like weren't Young Lords gang members involved, and thinking that that made sense to do, and it was what the community needed, and was willing to work. Were willing to work with them. It gets really involved. They like nobody got caught. No, it's just really cool, and I think other folks should look into it also. I don't know the name of the documentary. It was a New York Times little short thing we watched on YouTube. Oh, take over on YouTube. There it goes. Ryan just shot that in the chat if you're interested. Um, but yeah, and I think there's not a ton of harm reduction material in this specific training, but I think that is a great example of how, like, historically, so not public health harm reduction, but just like harm reduction from the community is really that collaboration between like folks impacted directly and folks who are not, but saying like, hell yeah, we need to do this thing and make people healthier. Alrighty, so this is the Meyer minority stress model. It's a huge web of arrows and boxes that say a lot of things, but in a nutshell, I think if you've ever understood or have talked about the idea of intersectionality, I think this deals with some similar concepts that skew a little more negative, right? So the Meyer minority stress model was a model created in the early 2000s to provide a framework for understanding stress processes in minority folks to help understand the negative health outcomes. So what this is saying in a nutshell is that Black and brown folks, or folks of historically marginalized identities, are going to experience external stressors and additional stressors in a way that folks who are mostly representative of dominant culture are not, right? So this isn't the stress that you experience in the morning when you don't set your alarm and you're late for work, right? This is the stress you experience because you didn't set your alarm, but then also you go into work as a Black or brown person and experience microaggressions, or you had a really awful doctor's appointment with somebody who wasn't acknowledging the pain or the symptoms you're expressing, right? This is going to be some of those external stressors and pressure. A lot of them which come from these structural ideas and influences, right? So structural racism, I think, is a huge contributing factor to minority stress, right? An increase in and exacerbating some of those negative health outcomes. So one of the things I like to share about minority stress is that it's unique, right? This is not the same stress that everybody's going to be experiencing, that even we are experiencing as clinicians or providers or case managers, whoever we are. So they're not experienced by all people. They're experienced by stigmatized folks who are required to adapt in ways that folks who are not stigmatized just don't have to, right? So that line right there on the bottom of the screen says that change that requires forced adaptation, right, is going to lead to stress and increased stress. And we know that increased stress, or negative stress anyway, distress, uh, is directly linked to negative physical and mental health outcomes, right? One of those might be that African American folks have been found to suffer elevated rates of hypertension, right? They have higher blood pressure than folks who are white. I think it is one example of that. If you think about really any of the social determinants of health and how um, those areas look a little different, right? Like, what does it look like to not be able to get to a grocery store and have like a family to feed? What does that look like? Is that a stressor that I've caused on my own, or that a client or someone you're working with, a consumer, has like contributed on their own, or is that kind of an external stressor? And does that energy and that frustration that you're experiencing as a provider need to be directed elsewhere or upward? That's also something Ryan and I talked about earlier today, is the idea that sometimes engagement is really challenging and really hard. So I love the idea of starting with like a, why should this person trust me, and having that in the back of our minds, right? But I think also understanding that probably, I just think it's super likely that our main frustration is likely not this person directly, right? But the many systems and external stressors that have led this person to this point, right? Has caused this person to not come to this appointment for the fifth or sixth time, right? Has caused this person to not be able to live or manage their apartment in a way that we deem as successful or housing ready, right? As just a few examples of what that might look like.
I also think about like the way that stress represents kind of like a cognitive overload for all of us, right? Like when I'm stressed, I'm just not thinking clearly. I don't give good presentations when I'm stressed, right? I don't do my work well when I'm stressed. I don't attend to my family well when I'm stressed. And so I experience in that case the letter C on the screen right here, right? The general stressors of living my life. Add on this external and internal minority stress, there's a cognitive overload there, right? So we're asking people to process what we're saying to them, right? We're trying to use motivational interviewing to help pull them into the process of treatment. How much of that is landing, right? How much is being received when you're on brain overload because of all of these structural factors, in addition to what I'm going through as an individual? So stress plays a huge role in just people's ability to like receive the messages that we're trying. You can craft the best lines as a worker, as a case manager or whatever, but is that person hearing you? And if they're not, why is it? And I think this stress model, I think, paints a really good picture.
Yeah, I love the idea of making this about you, the provider, right? Or about us. If you had a late night or didn't sleep well and you walk into work and you're cranky, you know you're not your best self or the best provider, and your stress is increased now, right? So imagine just how our folks that we're serving who like didn't sleep in their beds, right? Last night, or don't have a bed to sleep in, or have a home. And that's not said in like a, oh, your problems could be worse. That's said to like kind of normalize just the stress and the inability to engage, or the unwillingness to engage that our folks have when we're feeling challenged to engage, or we feel like they're being challenged to engage with us in a way that feels productive. Alrighty, the homeless service system. So I think one of the most significant takeaways, I think, from a training like this is to know that as providers, we are not immune to maintaining some of this structural nonsense that we're talking about, right? And I'm talking about it like I know what I'm saying, and like I'm the best person at this, but I'm not, and I have messed up royally in my career so far, and I know I will do it again, and I'll do it some more, right? But it's important that we're able to be aware of those things and to acknowledge them so we can change and adapt the services we're providing and the care we're providing for folks. So one of the things we want to start with is the idea that a colorblind approach to addressing homelessness does not work, is not real, and if it is, it's not very equitable, right? One of the things I think about here in the city, and I know Pennsylvania does it. I don't know if it's like a, yes, it is a national thing. The pit count, right, Ryan, is like a national thing, or just a Pennsylvania thing?
Yeah, Pitt is
National.
national. Yep, folks
Okay,
will know about that. January in every community in the U.S.
great. So this is like accounting a tally of the folks experiencing street homelessness, right? What we do know is, okay, look at the history of Black and Brown folks, right? And just the urgency and the necessity that to hide and to not be seen or discovered or heard, right? These people are not being counted on the street. In Philadelphia, we have our sort of like housing system, the way we house folks through pathways is it's completely referral based, right? They get these outreach contexts, they're referred to whichever housing agency, and then we house them, right? But there are many folks who are not being housed and counted, and I don't know the data, but we do know that we are referred many more white people than we are Black and brown folks here in Philadelphia to house in pathways. Multi-system level involvement is common for our folks. Our folks have incarceration histories, they've had psych hospitalizations, and just involvement in many different areas that have contributed to probably maintaining and increasing some of the stigma that our folks are coming to us with, and maybe internalizing and experiencing as maybe some shame, right? And might be resistant to care because of that, which I think speaks to another huge barrier to engagement, right? These folks are coming from other systems who maybe aren't very harm reduction oriented, or maybe use shame and guilt as a tool, right, for recovery or progress. So there might be some hesitancy to share or to share honestly and transparently specific mental health symptoms, right? Or specific substance use behaviors. And I think getting to a place where we are comfortable doing that and where participants are comfortable sharing with that definitely takes time and isn't going to happen right off the bat. And then also in those places exists institutional racism and discrimination as well. Yeah, that's what I've got here. And I think also just on the colorblind piece, while it's here, I think sometimes people say statements like this outside of the homeless service system and think that it's helpful or is speaking to some form of equity, right? But when we know, and we can talk about all these terrible things that have happened to Black and brown folks, this colorblind approach is actually probably harmful. So folks who are like, I don't see color, right? It's stop saying that. Yes, you do. And also, we need to, right? Because we need to provide services that are equitable for this person in a way that we might not be extending ourselves or providing care for folks who are mostly representative of dominant culture. And I think that is what equity looks like. And we'll talk a little bit more about equity in some future slides. Ibram X. Kendi said this quote. He has a cool book, cool TED Talk if folks are interested. And I think that this quote is actually pretty provocative, but like is a good challenge to kind of examine some of our own policies, procedures that we have in our own settings. He says, there's no such thing as a non-racist or race-neutral policy. Every policy in every institution in every community in every nation is producing or sustaining either racial inequity or equity between racial groups. And I think that's important to ponder and to think about when we think about if you are in a position to influence like policies and procedures of your specific program. I think really digging into the meat and bones, meat and potatoes. I suck at metaphors, allegories, whatever they're called. But when you get to like the meat of like of what these things are meant to do, maybe asking ourselves, is this for like safety or is this because I said so rule, right? And who is benefiting from this because I said so rule, and who are we like excluding and keeping down, maybe unintentionally, because of this because I said so rule.
Hello, I got a question in the chat that I want to uplift in an anonymous way. It was privately sent to me, but I think it's a good clarifying question for us as we continue. When the word brown is used in this training, does this include the Latinx community or anyone with brown skin color? I'll speak for myself. When I use the phrase Black and brown, or when I use brown folks as a phrase, I'm speaking about both of those things, right? Acknowledging colorism, right? And the relative level of stigma that people of different skin color receive globally, right? Darker skinned folks are more impacted by a lot of these factors that we're talking about than lighter skinned folks, but it exists on a spectrum. But I'm also speaking about folks from other brown communities, Arab folks, folks from Latinx countries, Spanish-speaking countries, etc. So I guess my short answer is both. Do you have anything you wanted to add there, Carlo?
Yeah, I think this is so I am of mixed races. My family is a very mixed race family. Um, I've had these conversations in like a professional setting and also like my personal life about just what this looks like and how we navigate the world. And I think it comes down to like what people are going to perceive of you without you opening your mouth saying anything, right? If you can look at someone and say they're not a white person, that might be a black and brown person, right? Or if you've ever met like somebody who is perceived white visually, right? Um, and they say, oh, like I'm actually like also Mexican. That is important to know and to talk with and work through, right? But the idea of someone being like white passing is also, I think, something to consider here. Also, right? Is this person having the same interactions that somebody who is black and brown is having based on like phenotype only, what they look like? And I think that's going to be an indicator of like we're talking, who we're talking about. Um, Conversations can get messy and like serious here. I've had people in my own life call me like a house slave, which was supposed to be like a term of endearment, right? You're not going to be in the field; you'd be in the house because of like your skin color, right? And I think the idea of colorism, that's also a space that's necessary to navigate through the lens of like intersectionality, right? Yes, I consider myself a brown person, but it's not lost on me that my skin is very light, right? My hair can do some wild things sometimes, but overall, right, I think people are going to treat me a little differently than somebody whose skin is darker than my own. I think those are just important things to name and to bring into these conversations. I'll talk a little later about having these conversations directly with participants and how that can help kind of forge like a healthier and maybe a more like communicative relationship. I rambled a little bit, but thanks for asking that question.
Yeah, that's a good clarifying question. Thanks for asking. So let's dive in a little bit more to some of these structural factors that we keep alluding to. And there's a couple that we want to highlight. And I want to hear from you all too in this next section about sort of factors that seem to be impacting large swaths of the folks that you're working with. So I'm going to name some factors that I think serve as barriers to engagement and that impact people's pathways into homelessness and ultimately represent challenges in trying to engage them and move them through that process into permanent supportive housing or whatever sort of option we have. And so some of the questions that we ask ourselves around engagement, what happens when folks refuse to engage in services? What's our next step? How do we approach that? Do we just sort of wash our hands of that? Do we keep trying? Are there institutional policies in place here? We sometimes give stories about this housing first model that we operate in, where some of our folks were unhoused for 10 plus years, let's say, and maybe we're on our engagement list for 5 to 7 years, but they were still on our engagement list, right? We were still permitted to keep trying to working with these folks, and ultimately we're able to see many of those folks become successfully housed, right, after a 7-year period of engagement. So that's pretty wild. But not every organization or setup has the option to keep these cases open on the long term without what the city would define as success, right? And so kind of asking folks in the chat to respond, why might participants, I would love to hear you chat here, why might participants have reservations engaging with you? Let's say you've got a needed resource, whether that's your harm reduction services, whether it's your housing services. What are some of the reasons folks might have reservations that are coming up for you? Jennifer mentioning trusting the system, right? One of our first couple of slides was like something around mistrust and like the obviousness of that and like the logical, how that's so logical and reasonable. Stigma, yeah, they don't trust. Ooh, Anna, I've made it this far on my own. I don't need your help. Right. And for some folks, the value of their own independence and autonomy, knowing that that system is going to curtail a lot of that. You're going to take decision-making power away from you as soon as I walk through your doors. Right. Why would I give that up? Even if I'm struggling now, I've made it this far on my own. I don't need your help. I think that's provocative. I love that statement. Previous negative experiences. Yep. Historical bad experiences. Shame, the power of shame. Yeah, we talk so much about shame and its component parts of stigma, as well as like being such huge drivers of behavior, and the way that shame is built into our culture, right? Thinking about sort of Protestant American values and the way that shame factors heavily into that.
Yeah.
Yeah.
I want to speak to somebody's in the chat denial that they need help. It's something that we hear often in this space, but I'd like to encourage and challenge and maybe provide like just another frame for this and thinking about and engaging with folks. I think one of the ways we might be able to think about this is um, in knowing the impact of stigma and shame in our systems, right? The systems that we are working in. I I think about somebody's um, just internal kind of dialogue of like, do they feel deserving or like worthy of that help and support because of what the world has told them for so long about maybe their mental health or their housing status or their substance use behaviors, right? And it's maybe if we can like crack through that and like, yes, you are deserving and we want to support you. And I think that's much easier said than done. That is like a full and whole process, and I don't think that people do this consciously all the time, right? But maybe just getting somebody to understand that they are deserving and worthy of help that maybe they haven't received in the past or ever in their lives or historically, whatever that might look.
Yeah. And I love that you mentioned that, Carlo, that like some of this stuff is operating unconsciously. And as we talk through some of these structural factors in the next section, not always can the person that's right in front of me be like, oh, it was this structural factor that led me to become homeless, and that's the challenge. But that doesn't mean it's not sort of operating and affecting people. Okay. So we're asking you to consider some other factors here, right? Their history, you all mentioned that. Fear, you all mentioned that. Their trauma history may play a role. I heard bad experiences come up, but even additional traumas that we haven't necessarily named could play a role. Where they're getting their self-esteem from, their substance use. I see Brenda put a long comment in the chat that folks don't necessarily want to be disturbed when they're getting high, right? And so their active use in the moment may be a factor in not wanting to kind of connect with you. I got my own thing going right now, and you're going to disturb that, right? And that thing that I got going on right now is like a key way that I escape, that I cope, that I deal with pretty awful circumstances that I'm living in many cases, right? And so why would I want you to disturb that? And so kind of the larger point that we're making here on the slide is that sometimes engagement is a very lengthy process. And we have to be prepared for that lengthy process. Doesn't matter how good you are at engagement. It's not just about you, the provider, right? It's a relational experience that we're in. And it's impossible to sort of predict how this thing that I'm going to do, this intervention that I'm going to use, is going to connect with you, the individual, or this other individual, right? There are different ways that people connect with these interventions. And so the follow through is key piece is meant to say that we have to keep going and going and going, recognizing if all of these structural factors have impacted people to the extent that they're difficult to engage, that's probably taken many, many years. And so the undoing of that, right? The developing the trustful relationship is probably going to take a long time too. I think many people have spoken to this next slide already, but a bit here on implicit bias, right? So just spending some time defining implicit bias are those attitudes or stereotypes that affect our understanding, our actions and decisions in an unconscious way, right? A way that we're not even aware of. So this is activated involuntarily. It's outside of our control. And it can be positive or negative, right? I think implicit bias is sort of presumed to be always a negative thing. And the truth is that bias is sort of just like a mental shortcut that we use to navigate a bunch of stimulus in the world, right? And so I'm relying on things like stereotypes to sort of like move quickly through the world, right? And sometimes that ends up causing a negative effect and sometimes a positive effect. But I think the key point here is that everybody is susceptible. We all have implicit bias, right? And that doesn't make you a bad person, but we have to do some work around uncovering that bias and managing it because that's going to affect the way that we connect with people, the way that we engage with people. There's a ton going on in the chat. So let me take a pause real quick to just like connect with some of this. I'll uplift Janice's comment. People being alone and having a sense of abandonment. Many fear that once they're sober and placed in their living situation, they'll be forgotten and alone. They will not have a supportive network, or their current network will abandon them. Hey, guess what? That's not just a fear. That's like a legit thing that plays out, right? People do become more isolated when they're housed, right? Especially if you're in a program like ours, where according to your use and occupancy agreement, your sublease that you sign, you're supposed to move in alone, right? How am I supposed to receive this incredible benefit of being housed when all the people that I care about and that care about me are not housed? How am I supposed to leave them behind, right? So that's not just only a fear. That's something that plays out every single day. Kimberly uplifting that point and saying that you've heard that a lot in crisis work. Fear that if I give up substance use, I'll give up all my friends and support network. This is the thing that connects us, right? And so giving up this means I lose everybody. Absolutely. These are great points. Thank you for shouting that out. Great. Okay. So we talked a little bit about implicit bias, how it's happening all the time, how we have a crucial educational role to play in like uncovering that so that it doesn't impact our relationships with people. A thing I want to talk about too, though, is that the folks we're serving, and Kalo mentioned that like people have like multi-system involvement often, right? They're involved in a bunch of these other systems: the criminal legal system, the education system, of course, the employment system, housing, healthcare. Oops, sorry, went too far. These are obviously structural things, right? Bias is built into each of these systems and the policies that operate these systems. And so people are interacting with these systems before they even reach us, right? And within those systems, there are individuals with their own implicit bias, right? So thinking about judges who make sentencing and bail decisions every single day, right? Their bias plays a role. They would love to say that it doesn't, but it does, both at the individual level as a judge and also at a larger level in terms of when we look at decisions made across judges over time, right? In the education system, whose behavior is perceived as misbehavior, right? And then who gets over-disciplined? Often Black and brown folks, students of color, students with disabilities, queer folks. And so another sort of thing that happens in the education system is that for these folks, teachers hold them to different standards, right? And so they give them less corrective feedback, which is kind of pernicious, right? It's like, oh, you come from a tough family life, so I'm not going to correct you as much. And then I don't correct you, and now you don't learn. And now you're not prepared for the next grade, and that progression isn't there. And so that can be so subtle and can be just like in the classroom. Maybe you've got this really unbiased curriculum, but one teacher emphasizes certain things versus another teacher, right? In the employment arena, we know promotions are given to people with more desirable subjective attributes, right? We talk about like attributes of leadership. Well, that's a very subjective thing, and who we sort of knight with that, who has that like quality of leadership, are often folks who are Black and brown. Let's just be sort of upfront about that, right? And who are given jobs. There's differentials there. Let's see what else do I want to highlight here. I guess the other thing I want to say is that people's experience across all of these systems is going to find its way into our work, right? In the mental health, in the substance use, in the homelessness services arena, especially if we're providing person-centered care. They're going to be talking about these experiences, right? And so I guess the thing I want to say is that this implicit bias can sort of stack, right? It can, yes, I was involved in the educational system and I received a biased experience. And then when I tried to get a job, I received this biased experience, which meant I was unable to get housing in the same way that I wanted to. And then I became involved in the criminal legal system, and that was biased. And so this sort of stacks on top of one another to create a very heavy burden for people to carry that goes unnamed, right? When you meet somebody on the street, you don't get to know immediately all of the ways that they've received bias and have had to sort of manage bias in their life. And it's quite a heavy burden. Okay. We've been dancing around this idea of stigma, the concept of stigma. And I think this is the through line of so much of what we're talking about today. So I want to spend some time defining it. It's a big construct. It incorporates a lot, but I like this definition that involves two primary components: a label and a stereotype. So the label, thinking about things like addict, junkie, right, druggie, these labels link a person. They take an individual and they link that person to a set of undesirable characteristics, right? A junkie is somebody who is manipulative. They lie to people. They steal. They're selfish. They're lazy. Yeah, Mary Kennedy saying crackhead, right? Crackhead would be the label, but we know about crackheads that they can't hold a job and they don't care about their family and yada, 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 right? It's like this constellation of things that make up a stereotype. The label is the shorthand that we get to slap them with and say, boom, you're this. And that's your whole experience, right? And so when people link a certain label to a person and they believe that stereotype, they react negatively to that person, which places this like social distance between us and them, right? And this happens even in our services system. I saw a study recently that said that mental health care providers tend to be the folks who carry the most mental health stigma, right? On just like sort of a blind survey, right? And I think that comes from vicarious trauma. And so it's not just that we're serving people, we're meant to be helpers, and so we've eliminated stigma. Stigma exists still in all of us, and I encourage you, I challenge you to think about who are the folks that you serve, who are the folks on your caseload, who are you're most like turned off by, who are the folks that you just like can't deal with, and like what stigma's operating. How would you label that person? What's the stereotype that makes up the behaviors that really turn you off of folks? And then I think what you've done is you've uncovered some stigma. And if you're uncovering that stigma, they're receiving that in many other places as well, right? And it's that social distance. How do we keep ourselves away from people like that? How do we not have to interact with people like that? Yeah, I'll stop there. Yeah, Madison giving an example. The opposite of clean is dirty. Yeah, when we talk about sobriety, and I've definitely tried to make this change in my own language, right? The stigma of like, oh, how long have you been clean? Well, I wasn't dirty before, right? And so kind of maybe using the term, how long have you been sober, could be an alternative to that kind of language. I see Kaylee's comment. There's a stereotype around public housing. Absolutely. And a stigma around that, right? The label, if you're in public housing, is you're lazy. Or I think maybe the label probably actually is public housing. You're a public housing resident, right? But the stereotype around that is that you're lazy, you're trying to suck the system for everything when there are people that are working their hardest but might be single parent. Absolutely, yeah. And so you've quickly identified that like this stigma operates not just with drug users, not just with mental health recipient like service recipients. It operates in so many areas of our society. Great. Yeah, welfare queen absolutely is a label that carries so much stigma and so much stereotype around it. So I think you all have a pretty good grasp on this concept. Let's talk now. I want to turn to this set of slides. And you've seen this if you came to our harm reduction training series. The National Harm Reduction Coalition says that stigma has some explicit purposes, or maybe they're implicit purposes, because people that are operating on stigma don't necessarily say this out loud. But they say that there are these three purposes, and you'll see those on the left, and there are these three impacts of stigma on the right. And I challenge you to sort of imagine some of your own participants and see in what ways they've experienced this. First, they say that stigma highlights difference, right? This difference between us and them, right? And I saw that us and them language come up earlier in the chat. When we highlight difference, when we note that there's a difference, we're creating a barrier between people, between groups, and that has an impact that it keeps people out. In other words, there's a good place to be. There's one side of the barrier that's good to be, and there's another side that's bad to be. And so when we erect this difference, this barrier, we're keeping people out, right? The second purpose that stigma has is it indicates that there's danger, right? Public housing recipients, drug users, people with mental health challenges, these people must be dangerous, right? There is a kind of almost instinctual process taking place that like, I want to keep myself safe, so I keep people away, right? And that's the impact that it has. It keeps people away. But the problem is that when we do this process of like label plus stereotype, and we really examine it, what we would uncover is that there's probably not actually any danger there, right? It's our own implicit bias providing that danger, right? Telling us that there's danger. And so we're keeping people away. The final purpose that stigma has is discrimination. And there's kind of this explicit stated thing that like, I deserve and you don't deserve. Right? We saw that in the public housing example. And what this does is it keeps people down. It doesn't allow for the possibility of people exiting homelessness, perhaps changing their relationships to substances, improving their lives in any way that is meaningful. And so what this does is it enforces this boundary between in-groups and out-groups. I see Kimberly's comment in the chat. Stigma can inform how a mental health worker believes they should work with a client. But they should come from the client themselves, their priorities, their concerns, not a predisposed stigma. Yeah, I think you're saying that like, let the person be who they are and we interact with the person in front of us instead of interacting with the label or the stereotype, which I would totally agree with. All right, let me hand it over to Khalil to talk a little bit more specifically about racial stigma in particular.
Sorry, I was muted. So on that first note, actually, Kimberly just did a great job at pointing it out. I want to come back to that. But first, understanding that perceived stigma can cause psychological distress and impair health, right? So how somebody feels like they are experiencing stigma, maybe specifically racial stigma, can increase psychological distress and impair, just have negative health outcomes, right? So that's without you even doing it or doing it intentionally, right? And I think that speaks to folks coming to us and coming to our care and our agencies with all this stuff already, right? Maybe with this perceived stigma about who they are and what they've internalized already. But I think alternatively, and to Kimberly's point, what we believe about a person and maybe the stigma and the biases we carry against this person or their people groups and who they represent also has a direct impact on how that person is going to navigate the world, right? So we might have to do work to, first of all, correct this in ourselves or address it in ourselves. It's not going to go away, but being able to learn to manage it and work with it in a way that is like not harmful to the folks we're serving. But then the extra step would be like, how do we unpack this internalized stigma that this person might be coming to us with already that maybe we didn't contribute to ourselves, but these other systems and other agencies might have. And then we have the idea of cultural stereotypes and prejudice impacting the development of the self-concept and identity of individuals. And I think this speaks to that idea that maybe folks don't think that they're actually deserving of any help because of these identities that they've assumed or the identities that folks tell them they are, and whatever that label is, right? That stereotype we talked about. Some may think, oh, I'm a junkie, right? I don't deserve to be housed, is what this might look like, right? Or I'm having trouble thinking of like a race example, and I don't want to because I feel like it might come out bad. But what people think they deserve, I think, is just another important component to this. I mean, that self-concept and identity can really be lifelines out of homelessness, right? Or maybe even substance use. And what we've seen is engaging people in community and getting them more involved in community inclusion and some like social activities have really been super beneficial for folks, right? What does it look like to help somebody connect to or to reconnect with some specific, just like cultural items or ideas or themes that just feel good in affirming of who they are and their identities. I also read a recent like article about how like community organizing and activism and protests can also help to increase and improve mental health outcomes for folks too. And I think at this point right here about cultural stereotypes and prejudice impacting self-concept kind of reminds me of that also. And where people encounter racism, they're less likely to engage with services. I think this is another idea that can be applied to our lives. If you go somewhere and you receive care that doesn't feel good to you, you're probably not going back if you don't have to, or if you can avoid it, or if you have the resources to avoid it, right? I think we can think about our clients in the same way. Maybe they don't have the resources to just pick a different provider or the support to pick a different provider. Whereas it might be a little easier for us, the helping professional, to be able to do that and move around that with a little more ease because of our like insurance or our health and benefits and whatnot from work. But yeah, I like to share an experience of my own life where I had one of my wisdom teeth out at a dentist that I felt like treated me horribly. And I don't know why, right? But my experience overall was very bad. I was like in a headlock, which maybe is normal, right? But my dentist like arm was around my neck. I have like a specific like anesthetic allergy to like lidocaine, so I was in like a lot of pain. I was not asleep, and it was just a really awful experience, right? So I needed all four of my wisdom teeth out, but I immediately knew that I was not going to go to that dentist again to get the rest of my teeth out, right? What's different for me and the folks that I serve, though, is that I have a lot more social supports. If I didn't have the energy or capacity to be like, I don't want to find another dentist, I have folks I can rely on to like help me through that process and navigate what that might look like, right? Whereas our participants don't always have that, and sometimes we are that for our participants, walking them through those processes and navigating medical care. Someone said same. I'm glad I'm not alone there. But yeah, if you experience bad care, if your friends are bad to you, right, you're not going back to their house. Same thing can be applied to the folks that we're serving. Microaggressions. All right, this is, I think, can be actually really fun, but also uncomfortable. So engage at will. But these are the verbal, behavioral, and environmental indignities that are actually pretty commonplace. And I think if we think back to our own services and systems not being colorblind, it's going to be really important here, right? We experience microaggressions on a pretty regular basis, but also we are sustaining them and maybe executing them on a pretty regular basis also. I need to kind of check ourselves maybe. But these are the things that communicate hostile, derogatory, negative slights and insights, right? A common one might be, you speak good English, right? Or, oh, you sound white, or you talk white, might be another microaggression. Maybe somebody's actually saying you speak intelligently, or like you are articulate is, I think, the perfect example for the workspace. And the question that somebody might be asking themselves when you say, oh, you're actually really articulate, is like, well, why wouldn't I be, right? I'm here, I work in this space, I exist in this space. Why do you think I wouldn't be articulate, right? Um, and this can be intentional or unintentional. And I like to make clear here that some people think they're saying a really good thing or doing a really good thing, right? Like, oh my God, your hair is so pretty, right? Can I touch it, right? And then they just touch it, thinking they're being complimentary and affirming and uplifting to somebody who like maybe doesn't want to be touched, right? And isn't like your laboratory to touch black hair. I think it is an example of this where someone might mean well, but maybe be doing some harm. Um, these are brief and commonplace, right? They're happening on a pretty consistent basis. And these can be broken down further, and we're not going to go into these individually, but they can be broken down further into micro assaults, micro insults, and micro invalidations. And I think some other things or other ways microaggressions can be disguised are might be like written into policy, right? Maybe some dress code stuff for school, for young folks, but also in the workplace for us and for you about maybe how we're wearing our hair, what we're wearing, how we're communicating, communication styles, what positions people are holding, who they're in charge of, how we handle power and direction are all examples of like how microaggressions can leak into the workspace are important to be weary of. One of the notes here we have is that folks who are mostly representative of dominant culture frequently view these microaggressions as trivial and not a source of harm. right? But this helps to reinforce the idea of stigma. And if left unchecked, people think that that is okay, right? Um, I'm trying to think of some other examples, but instead of me doing that, if anybody has examples of like microaggressions in your own life that you might have experienced or that you know that your clients experience on a pretty regular basis, feel free to unmute and share or add them in the chat. Renee shared one off the bat that says, I used to get told this all the time. You're so pretty to be dark skinned. Not a compliment, definitely a microaggression. The dark skinned people can't be pretty. Absolutely. This is a microaggression. This is like a textbook example of a microaggression, right? The underlying theme or messaging here is that like dark skinned folks can't be pretty or attractive, right? Absolutely an example here. Any other examples here? I think the idea of code switching is something interesting to explore. This is maybe a little bit more complex to fit into like the microaggression category, but I think often code switching is framed as like a good thing as a skill for Black and brown folks to be able to do. One of my favorite media channels on YouTube is called Jubilee, and they do a lot of like cool like social experiments and conversations. And in one, everyone's blindfolded, and they were all Black women, and there was one Asian woman, and through their conversations, they had to guess who was not Black. They had to guess who the person who was not Black was, and it was to go to show that maybe these folks had more in common and blah blah blah. But one of the questions that they had for these folks to explore and to do and to try to root out who wasn't Black or who wasn't a Black woman was they were like, let's hear everybody's customer service voice, right? Was what they said, which really what might be under there is like, let me hear you talk not Black for a second, right? I think was the messaging there, which is really interesting to see. Looks like we have some other things in the chat. You're so lucky to have to tan or not have to tan might be what this is supposed to say. Yeah, your skin might just look darker, right? Yeah, absolutely. Like, what? You having a thick accent, but articulate. Oh my gosh, yeah, folks with accents or whose first language may not be English, like, can't also be articulate, right? Or this accent means you should be like less literate. They need to learn English due to a Hispanic accent, even though they're speaking clear as day English at the time. Absolutely. A white coworker or client saying, hey girl, or hey dude. Yeah, I think this is gender also plays a role here in microaggressions, a big role, right? And this is important to explore also. Assuming that someone speaks in that language based on their skin tone. I like to give an example of, I used to work at a produce store, and mostly everybody spoke Spanish except for me. And one time I was like checking out this white lady, checking out like ringing up her items, not like manly checking out, being gross. I was checking out her items, ringing up her items. There we go. And she started talking to me in Spanish, and I said, oh, I'm sorry, like, I actually don't speak Spanish. And she said, oh, no, it's okay. I want to practice. And I said, oh, no, I don't speak Spanish, right? She wanted to practice her Spanish on me because she perceived me to be a Spanish speaking person, which might have made sense for the environment. But even after me saying, I don't do this, and it's not a skill that I have, she's like, I need to practice, right? Yeah.
I also think I just want to like bring this into like the service setting a little bit more. I'm seeing examples of people like talking with their coworkers, and so I'm glad that you're able to sort of like understand the concept of microaggression, and you're identifying, unfortunately, many examples in your day-to-day experience. I think also as service providers, we are the purveyors of microaggressions pretty regularly. I saw some folks talking about the opioid epidemic earlier. We've got folks on our teams who are like very highly educated and have been homeless for some years now, right? And so the expectation, though, is that if you've been homeless, you're like uneducated or like incapable, you don't talk well, things like that. And so I the point of this slide being here is both that our participants have been the recipients of microaggressions probably over much of their lives related to their identities, gender identity, racial identity, related to their status as a substance user, a mental health recipient. This is happening all the time for them. And that also we are doing this to them, probably in ways that are worth uncovering a little bit more closely. So yes, this is also happening in our personal lives. And yes, we are probably also doing this, especially if we don't share that specific sort of like identity category with, there's a cross-cultural relationship happening in some way. And so we're likely to make some mistakes there.
Awesome. I could just one more. This one I think really speaks to your point, Ryan. Somebody shared that they have had people tell them they couldn't be sensitive because they were Black and needed to act tougher. And I think this is the perfect example of what we've been talking about in this internalized sense of self, right? For maybe folks who like are resistant to engaging because they think they need to do it on their own because of that messaging that they've received for so long. But I think this is a perfect example of that, and how we might be a lot more similar to the folks that we're serving than not.
All right. I think this is a good stopping point. Let's take a pause. If we can take a 5-minute break, we have a good bit more content left, but I think we're on track. So let's take 5 minutes. I have 28 past the hour. So if we can come back at 33 past the hour, we'll dive back in and continue this section. All right. Thanks so much for sharing your experiences with microaggressions and some of those. It's always interesting to see like what people have experienced and the way they relate to it. So that's helpful and illustrative. Diving in now into some of those other structural factors that people possibly have experienced as individuals, but also groups of folks have experienced who are Black and brown in our homelessness services system. So this is maybe seems like a bit of an obvious one, but poverty itself is a kind of a key factor that leads people into homelessness and carries its own specific set of stigma, right? I keep going back to this example because nobody had ever said this example in the training before, but the public housing example is one, right? One of the components of public housing is that it's associated with poverty, right? And poverty has its own stigma that's attached to it. But in terms of like what leads people into homelessness and the way the poverty is operating at the structural level, we have to point out the racial wealth gap, right? And so today, white folks possess about 12 times the wealth of African-American folks in the United States. Part of that has to do with incomes, right? So like the income, the literal income that white folks are making at their jobs, at their salaries, at their businesses, they're accumulating wealth faster because of that income. And sort of low income increases the risk of homelessness, obviously, and reduces pathways out of homelessness. I read a statistic that said something like 40% of folks are like one $400 charge away from housing precarity or like becoming unhoused. Many of us are not as like sort of stable in our finances and in our housing as sort of the American dream would lead us to believe. And then also within people who have experienced homelessness, within that data set of people with slightly higher incomes, that is a predictor of more stable housing trajectories in the future, right? So income plays a pretty big role there. We also know that there's this role of employment discrimination that leads people towards poverty, or that has a factor in poverty. So Black Americans are twice as likely to be unemployed as white Americans. And then when they are, their wages lag behind. There continues to be strong evidence of discrimination in hiring decisions, who is hired and why. And then when people are employed, when Black and brown folks are employed, they tend to have less stable employment. In other words, they lose those jobs more frequently and more quickly than white Americans. There's also this component of the credit market discrimination. So Black and brown folks have higher rejection rates and less favorable rates overall for mortgages. And this is pretty key because homeownership ends up being one of the most significant sources of wealth accumulation. So that stat in terms of the racial wealth gap, a big factor is homeownership. Who owns a home and is then able to pass down that home sort of generationally is racially defined and racially bounded. And so when folks are rejected for home loans or they get worse rates for their home loans, they're not able to accumulate wealth, and that serves as a buffer to protecting them from the experience of homelessness. Incarceration is another big factor in terms of poverty, right? When you think about families and pooling resources together to help each other, and somebody in that family unit becomes incarcerated, that's going to destabilize the entire family. And it's going to, of course, also impact eligibility for public housing options down the line. And then just finally, a word about wages. I'll end here. There's not a single state in the United States where a full-time worker working at a minimum wage can afford a 2-bedroom apartment at the fair market rate. So we know that there's an affordable housing crisis, but even besides that, wages don't keep up with survival needs, right? And so that's going to be particularly impactful for Black and brown folks. I want to make a note here too about income inequality, and I want to make this distinction that income inequality is different than poverty, right? So think about your big heavy hitter cities like San Francisco or LA, where there's a ton of wealth there, right? Even New York City, right? There's a ton of wealth. Boston and Philadelphia would be good examples of this too, actually. I think about Silicon Valley. I think about Hollywood. I think about Wall Street. I don't know what Philly has. Philly doesn't have anything good like that. In these places, there's also devastating homelessness problems, which sort of doesn't make sense. There's all this wealth in this place, but then also this like significant homelessness problem. So to me, that says it's not just poverty alone that contributes to this problem of homelessness. We already talked about the fact that homeownership plays a pretty big role in the racial wealth gap, and there's an inequality built in there, right? Income inequality in terms of who can have a home, and then ultimately sort of like the size of the home, the shape of the home, the upkeep of the home, etc. And so that racial wealth gap continues to be widened through housing discrimination. Another component of income inequality here, insurance rates. It plays out in the auto industry, for example. So cities and towns with majority Black residents end up paying the most as compared with other areas of any other racial makeup, right? So it's not just sort of like the income inequality, but the expenditure inequality as well, where Black folks are being asked to pay higher rates on their insurance, right? The same is playing out for majority Hispanic neighborhoods, who pay more than majority white neighborhoods. When there is, and this is a measurable thing, when there is a high level of income inequality in a location, in a community, or in a state, a city, or whatever, that increases the likelihood that low-income folks will become homeless. What we see is that a shrunken middle class, right? You've got like a top-heavy upper class and a really big lower class. When you have that shrunken middle class, fewer new homes are being built for middle-income households. And then there's fewer hand-me-down homes for lower-income households, right? And so it impacts in almost this sort of trickle-down way. And it also causes higher rents for the few units that do exist, right? And which we see in places like New York, San Francisco, LA. It's like impossible to afford to live in like city centers for almost everybody. Yeah, so we have this increased cost and decreased stock of affordable housing when there's high income inequality. Of course, the way that we deal with income inequality, presumably in a social democracy type setup, would be that we tax the high earners and we provide benefits and subsidies to lower earners. That would be the way that we sort of like shrink that gap. But what do we know here in the US? Benefits, or maybe another way of calling that is welfare, is a racially stigmatized thing, right? Somebody already brought up in the chat the myth of the welfare queen. And so if it's stigmatized to even receive those benefits, we're going to make it harder for people to do it, and they're going to be unlikely to do it. And we're not going to see the problem of income inequality addressed at all, right? I see a comment in the chat. Housing developments where the 40-year mortgage or opt-out, the HUD Section 8 contract has contributed to the housing crisis. Absolutely. And we see tons of policies that way. Actually, Cull is going to walk us through a little bit of like the kind of the history of some of this housing discrimination that contributes to homelessness and ultimately makes people tough to engage.
Yes. So this might be a map that folks are familiar with, or at least familiar with what this might be. This is a redlining map. Um, Another example of a great example of structural racism. One of the idea, before we kind of unpack just like redlining specifically, but we know that folks are like buying stocks and like housing and like rental properties, right? Um, and I think that idea in and of itself is like, okay, this is a financial instrument and not like a necessity for folks to live and maintain safety and live their lives, right? Um, so Ryan covered housing affordability, but redlining um, was a systemic housing discrimination supported by the federal government, right? So this is another when we're like, well, why don't you do these programs? It's like, well, here's what the government has done in the past, right? Very intentionally, and has like made things like racism legal and wrote it into legislation on paper and made things like this okay, right? So red lines on a map indicated some neighborhoods were ineligible for federal home FHA mortgages, right? So we don't want folks, Black folks specific, to live in these areas, right? Or we only want them to live in these specific areas. So what they did is create a very racist tool to note where folks couldn't and couldn't be, right? So and even in how they were kind of grading or rating these places, I think speaks to the idea of racism and speaks to like the shame and stigma that folks were experiencing, are still experiencing because of systems like this, right? So if an area on a map was green, right, it was called the best, right? This was the best areas to be and to live in. We wanted folks there. We wanted white folks there. These blue areas that you see on a map. This is a map of Philadelphia, by the way, if I didn't say that. These blue areas on the map were given the B rating, right? And B stood for still desirable. C, if an area was given a C rating, it was yellow. And the kind of code for this was definitely declining. And the areas that are red here on the map received a hazardous rating. And even the presence of maybe one Black or brown family in these areas got this red rating for folks. So this is one of the examples. Redlining has created just enduring discrepancies in home ownership in cities across the United States. One of the things we know today in Philadelphia, segregation anywhere is not legal right now in the United States, but is a thing, right? And things like redlining kind of made, I think, outlined the idea of segregation as like being a legal tool and instrument to maintain this separate otherness and distance between folks. So Philadelphia still looks like this today, and like Black and brown folks living primarily in these red areas here on the map. So we wanted to push people there, right? And then we wanted them to stay there. We did a training with Nashville, and we found their specific redlining map there. And one of the interesting things about Nashville is they also had a crane watch. There might be something similar for Boston or Philadelphia, but the crane watch was to outline and pinpoint where current like construction and like home developments are being put up, right? Multi-million-dollar residences for folks. And guess where they're going, right? Also in these red areas, right? So after we've pushed all the Black and brown and poor people out of these spaces, we're now creating multi-million-dollar residences where these folks cannot afford to live either. So where do those people go now, right? That's one of the contributing factors to somebody experiencing street homelessness, right? Is not being able to afford that housing anymore. There is a fancy buzzword for this called gentrification that folks might be familiar with. So in addition to redlining, we have things like exclusionary zoning, where multi-family residences can and can't be. Who needs those residences? We talked about the rental market. And of course, we can't talk about the housing crisis and enforced kind of segregation without also mentioning like the forced relocation and genocide of many Native Americans who lived in these spaces as well. Um, so that's redlining. It is like a huge, complex conversation, but I think that is very surface level explanation, and folks might be familiar with this already. But I think we say this to say this is an example of structural racism still having an impact today, right? And where folks live, are receiving services, are going to school, which brings us to the next point, right? Redlining also has a direct impact on education, right? Individual schools and entire districts in historically redlined areas, right? So those red areas on the map are serving primarily low income and Black non-white students. They have less district per pupil revenue, but the highest need due to income status, right? So we know that folks and students in these schools have families that are making less money, so they are the highest need. But we also know that these schools are receiving the least amount of resources. They have less money to address specific education needs, even, let alone health and mental health needs for those students. But in addition to less revenue, there's going to be less opportunity, right? Less extracurricular activities, less individualized learning, which we talked about. We might have mentioned briefly the school to prison pipeline, increased consequences for Black and Brown children in schools in these settings. But then also the preparation and the resources that folks have, that these schools have to talk about and engage around higher education and maybe next steps in education, folks are very limited also, right? Which speaks to another structural factor, right? If the school doesn't have this, how does this child learn what they could have access to, right? If they're not exposed to that and if their school doesn't have the resources.
As you can tell, we're kind of like walking our way through some of these social determinants of health. And so kind of just a few more notes here about access to quality care. So folks of color are more likely to lack health insurance than white folks, right? And if you're a person who's dealing with substance use challenges or mental health challenges, that's going to be a key risk factor for homelessness, right? Do you have the what it takes to pay for care to go deal with your mental health or not? Perhaps you have insurance, but you're not able to access the best doctors or the best care, the best facilities based on who takes your insurance, right? What we do know is that mental illness itself doesn't vary by race, but access to treatment does, right? And so folks of color are bearing a higher burden of the mental health challenges, right? It's not that the rates across races are different, but the impact is different across races, right? Yeah. And then the experience of homelessness then has this additional impact on health, right? And I bring this up because if you've ever dealt with a significant health challenge, I was talking about cognitive overload with stress earlier, and this comes with its own overload, right? Dealing with your health is really difficult. The medical system feels confusing and overwhelming at times, right? And so it's already hard to access that system. It's already hard to feel like you're getting good care. And then if you're experiencing homelessness, that just like ratchets up the difficulty, right, for you. And it's why we see so many of our folks just simply won't access care. The folks that need health care the most are the ones not accessing care. My colleague Renee is new to the role. She's here in the training today, and she's been chiming in the chat. And she was talking about the other day, talking about like the impactfulness of seeing so many young folks with like amputated limbs as a result of opioid use and infections and wounds. And so much of that probably could have been avoided, but it wasn't, right? For so many reasons. And among those reasons is probably just how difficult it is to access care or feel good about accessing healthcare, right? Feel like they're accepted, that they're not going to be stigmatized for their drug use, et cetera, right? So compared to the general house population, folks without homes have been and are now more severely impacted by social determinants of health. So they tend to have increased mortality, more chronic health conditions, greater challenges with mental health and substance use and other risky behaviors, right? So it's hard to sort of like point the directionality, but Folks who are homeless have harder times with this stuff. And of course, they're going to be more likely to face extreme poverty and be unable to even deal with their health. Some words about incarceration here. I know we're kind of covering some ground over and over again here, but just to kind of paint a clear picture, folks of color are incarcerated at higher rates. That should be obvious if you live in the United States. And folks who have experienced homelessness and who are folks of color report higher incarceration histories, right? So we know that people of color are incarcerated at higher rates, but also our homeless population, when they talk about their lives prior to arriving at this moment in front of us, tend to report greater history and greater involvement with the criminal legal system. Unfortunately, being incarcerated makes you 10 times more likely to become homeless down the line, right? And so kind of piecing these together, the challenge is, why are people difficult to engage? Well, it's likely that they have a high level of involvement with the criminal legal system, which I don't know if this is a surprise to anybody, but it's not really a rehabilitative system, even though we sort of still try and pretend like it is, right? And so in terms of survival strategies and coping with a long sentence, it seems pretty obvious that people are learning strategies to survive that aren't necessarily the ones that are going to allow them to best fit in society. And we mentioned the way that incarceration does destabilize family finances and impacts eligibility for benefits. Of course, it also makes people unable to pass background checks for housing and employment, right? So why did they become homeless? Well, they couldn't get a job. Why couldn't they get a job? Well, they had an incarceration history. That's like long in the past. Why is it still impacting them? But it still does, right? Okay, let me pause there. I'll just take a peek in the chat. Yeah, I see this question. How are the impacts of mass health or national affordable healthcare plans provided for low-income population? Not sure if I totally understand your question. Would love to kind of hear more, but certainly all the folks at Pathways are eligible to receive Medicaid. So they do have insurance. I think that's your question around how are they accessing medical care. Unfortunately, I'll speak for myself. My experience in interacting with providers of Medicaid is that these are like folks who are very dedicated, but are like under-resourced themselves, right? Like the Medicaid rates for reimbursement are not great for hospitals, right? And so they're overworked, they're overburdened. FQHCs are kind of a rat race a little bit, even though it's like a needed thing that's really helpful for folks, but ends up being not as good. Yeah, I see a comment on adverse childhood experiences contribute to all this. And I think we're going to kind of tie that together in our next section in terms of trauma. Thanks for saying that. Yeah, more stuff about Boston happening in the chat. Let me move us forward because I'm starting to get a little nervous about time, and I want to make sure we cover everything. Okay. We talked a lot about stigma so far. We've talked about these structural factors. And I want to make some comments now about in-groups and out-groups. If you're familiar with Maslow's hierarchy, you're familiar with this triangle that you see on the screen. And one of the key human needs that Maslow talked about in their theory of human motivation is that belongingness is a key human need, right? And so the way that we achieve belongingness as human beings is we identify with people who have similarities with us. Racial groups, ethnic groups, socioeconomic status, parents associate with other parents, right? This is like sort of a basic human process that enables us to fulfill this need for belonging, to be a part of a group of shared understanding and shared norms. We're kind of talking around the idea of culture right now, right? And people tend to favor other people who exist in similar groups as them. If we play the same video game, I'm going to have more to talk about with you, right? And I'm going to like favor you. You're going to be a person that I'm more interested in hanging out with and talking to and giving stuff to. And this happens in all kinds of groups. And in fact, this process of favoritism that happens within groups, that tends to play a bigger role in discrimination than hostility towards outgroups, right? And so more frequently what's happening is it's not that people are like outwardly discriminating against other people, although that of course does occur, but more frequently what happens is that we're just giving more attention, more energy, more resources to the people in our shared groups, right? So some examples. An employer might choose one candidate because they went to the same college as them. They're not per se outwardly discriminating against people who went to a different college, but when they find that candidate that they want to hire that went to the same college as them, it's like, something about you, like I can't put my finger on it, but I like you, right? Or kids who let another kid sit with them at the lunch table because they play that same video games, right? That's in-group favoritism as opposed to out-group hostility. So I want to say that kind of one of the big in-group, out-group dynamics that I want to point to is this idea of dominant culture, right? So in a place like the United States or a place like the Boston area or Philadelphia, we find that there are many cultures. We sometimes talk about ourselves as a melting pot, right? So many cultures can exist in a single society. But the culture that exercises the most power and influence is what we would call the dominant culture. And we see the way it's dominant through who has economic power in that culture, who has political power, what are the social norms and who do they favor, what are the laws, what are the values and traditions, and who do they favor. And so often what happens is that dominant culture tends to have a big influence on other cultural traditions. So in the US, the dominant culture is English speaking, it's Christian, and it's white, among many other cultural factors, right? So when there is a power dynamic present between somebody who represents dominant culture and somebody who does not, there are a number of processes that can unfold and a number of things that we as providers need to be cautious to guard against. Let me actually invite some comment in the chat. I wonder if there are some ways that you can think of that you and your staff, colleagues at your facility, at your residences, at your service provider, at your service location, what are some ways that you're seeing dominant culture play out, right? So I see Marianne saying, I often see that good manners are defined by the cultural norms. Is there a term for this phenomenon? I think we're talking around it right now, right? Just like dominant culture. Marianne is told that you're rude a lot. Well, that's rude. Emphasis on certain sports. Let's bring it into the kind of like culture, the service setting that we're in. In what ways do you see dominant culture playing out in your facilities? Kalo, we've done this training before and you've had some examples of how you've seen this play out. I wonder if you can share any of it. No.
Yeah, if you've ever been responsible for transporting participants, some agencies have it written in their policy that folks are transported in the backseat of the agency vehicle, right? Why does this problem, like, why is this a rule, right? If there's been like a history of like a participant maybe grabbing the steering wheel, a very kind of real life thing to do is have them maybe sit in the backseat next time, right? This isn't happening very often or ever. Maybe it's perfectly fine for them to be seated right next to you in the passenger seat like we would in our own lives, right? I am like your chauffeur, I'm your service provider, I'm taking you somewhere, we're not friends, this isn't a connection, I think is one example of like us sustaining this like maybe harmful power dynamic sometimes in the workplace. I think also if you've ever worked in a shelter setting, I used to work in a shelter setting for young folks, and food was locked behind cupboards, right? You had to like unlock it with a key for folks to have access to food. For anybody who's ever experienced like food insecurity in their life, this is something that's probably pretty harmful or reinforcing of things that they've experienced in their life, right? Also in the same setting, the youth shelter, the youth had to eat only in the dining room. Perfectly understandable. Reduces critters, mess, cleanliness things there for the shelter, right? And this wasn't an overcrowded shelter, right? 12 youth max at the shelter. But staff could eat and drink wherever they wanted in the shelter, right? Just because they're staff, um, which also is a very observable kind of power dynamic there. An example I think of um, kind of dominant culture there. Are these examples you're asking for, Ryan?
Yeah, exactly.
Oh,
I'm
okay.
curious to see like how power dynamics are playing out in people's workspaces with their participants.
Mm, yeah.
Rachel
Renee,
gives this good example of a benefits package. What one may see as a benefit, another may receive no benefit from, or may not even be able to access their current employment status or rate. But yeah, like the benefits package itself is a kind of a culturally defined, dominant culturally defined like set of things that are valuable for people.
Renee gave a good example of like what it might look like in the work context too. We might have somebody's payee-ship. We might be their payee, right, and receive their social security benefits, um, and be the person delegating their expenses, right? So if we have no option but to be that person, right, I think navigating that situation that in a way that is like supportive and as therapeutic as it can be with receiving all of somebody's funds is going to be really important, right? And also having somebody's keys, right, to their home and what that looks like, right? Um, at Pathways, if folks aren't home for home visits, we are supposed to key into their apartments and be doing a home visit anyway, even if they're not there. So what does that represent to somebody? Or are there things we can be doing to help avoid that, like making sure somebody's as informed as possible about when a home visit is going to happen, what happens if they're not there, and that sort of thing might be something we can do to kind of reduce that specific power dynamic.
Yeah, I love that. That's great. Like additional pieces there. So, and there's some good stuff happening in the chat. So I just want to kind of put a fine point on why this slide is here and like why we're talking about power in this way. We talked about all these structural factors, right? People can see this stuff playing out, right? The participants that we serve are coping with these like structural barriers every day, and they see who has wealth, who has power, who is dominant culture in their society, and they see the ways in which they don't represent dominant culture. The same thing plays out in our service spaces, right? And all of these dynamics are playing out every single day. And so when we ask the question, why are folks hard to engage? If they're seeing this like microcosm of larger dominant culture that they've been excluded from, they're going to be unlikely to want to engage with that, right? I'm excluded in the big world, and I see myself being excluded here as well, right? And so anytime that there's a power dynamic, people are going to want to control their own lives, their own destinies, and help themselves. And that power dynamic represents a blocker, a barrier to that, right? And so when we talk about harm reduction as sort of like handing the power back over to folks to make the decisions that make sense for their lives, what we're talking about is breaking down this piece here, right? Power as a barrier. Yeah, I see Marianne, I have a client right now that's trying to provide community housing, but puts lots of restrictions on residents. The more restrictions, the more we see examples of the power dynamic. And the more people are going to run away from that or be tough to engage, quote unquote. Yeah, great. A lot of good stuff happening in the chat. Thank you. Okay. So we've covered a lot of ground so far. We've spent some time understanding social determinants of health, the minority stress model. We've looked at some very specific structural factors that impact people's lives overall. That is often racially defined and defined by stigma and shame. And I want to turn to some of the ways that this affects people directly, individuals directly. So what you see here on the screen is a list of symptoms and responses to trauma. I wonder if this list is familiar to you, right? In terms of when you think about who are the folks that are difficult to engage, right? Folks who dissociate or have blunted affect, folks who have a ton of confusion, or maybe folks with continuous distress without periods of calm or rest. Right? These are some of the behaviors that I think about when I think about folks that are tough to engage, anger, rage and mood swings, aches and pains, social withdrawal. And so what I want to say here is that these are some, not an exhaustive list, but some very common symptoms and responses to trauma. And I want to note that these are normal and adaptive responses, right? This is the way that human beings cope with trauma. These are typical approaches and typical sort of ways of being affected by trauma, right? And so it's obvious that if you're experiencing feeling numb or disconnected, it's going to be tough to get that person to engage with you, to have a conversation about next steps, or to do future-oriented goal planning. And I want to state here that when people have experienced trauma, which is like our short and easy way of defining trauma might be somebody who's experienced a loss of safety and a loss of control, that there's a pretty well-documented connection between when people experience trauma, they tend to engage in risky behavior after that, right? As a way of coping, as a way of dealing. Their lives just become riskier, right? They're making different decisions to cope with that trauma. They're trying to give themselves back a sense of safety and a sense of control. And we also know that if we're not focusing on that trauma in our work with folks, unaddressed trauma tends to increase the risk of mental health and substance use disorders, right? And then lastly, when people engage in high-risk behavior, if we're not approaching that through a trauma-informed lens, through a harm reduction lens, we're going to be contributing to cycles of shame and stigma, right? And so people are going to hide this risky behavior. They experience a trauma, they become tough to engage, they engage in high-risk behavior, like let's say shooting fentanyl. That's already a shamed and stigmatized set of behaviors. And if we, the provider, are reinforcing that shame and stigma, it's going to push people away, right? And so just trying to kind of draw the line between what we're seeing out there in folks and the way that we interact with them is going to have a major impact on how easy it is to engage with them.
Okay, so on that note of trauma, we have here an image that might be familiar with for folks who are familiar with adverse childhood experiences, right? Or the ACE study, which was a big study, took place over 10 years, right? A longitudinal study, and was a 10-measure survey of the adverse childhood experiences that folks might have experienced in their childhood, right? And what that study resulted in was the idea, the evidence in the data that folks who experienced more of these things that you see here on like the surface level, the tree kind of space, were also more likely to engage in those risky behaviors that Ryan mentioned, but also have a higher likelihood for really a whole bunch of negative health outcomes. That's how I'll explain it here, because folks I feel like might be familiar with this. The one that I like to highlight the most is just premature death, right? All these negative things and health outcomes, but also like just dying before adulthood, or maybe a reasonable age. And I don't know what that is, but whatever. Feels gross, right? If you experience these things, bad things happen at an increased rate. And one of the things that we know about the ACE study as it is for just these adverse childhood experiences is that Black children are more likely to have higher ACE scores compared to white children. And I think this speaks to the idea of really racism and structural racism specifically being kind of at the root of these traumatic experiences. Things like parental incarceration, neighborhood violence, poverty, are going to be examples of this. And if we look at the bottom of this, this is kind of like the ACE study expanded, right? And includes some adverse community environments. So when folks are experiencing these like big T traumas, right, these specific isolated incidents, maybe, in addition to community environments that aren't like conducive to health and wellness, right? They're at an even higher rate of all of those terrible health outcomes, right? Yeah, and I think one of the things, if you're familiar with the concept of complex trauma, right, repeated exposure to these negative or adverse effects, right, I think that is also what we might call these things here at the root and in these community environment experiences, right? Things like repeated exposure to violence, living poor, repeated discrimination, which we've talked about that impact already a lot throughout this training, community disruption and lack of opportunity, economic mobility, and social capital, right? All of those social determinants of health there also contribute to the rates of trauma that folks are experiencing and the negative health outcomes that come with a higher ACE score.
Can I just put a really fine point on this? I think that the big point that Khalil is talking about right now is that all these structural factors that we've been talking about, that is trauma, right? Point blank. Those experience being on the receiving end of like you're not a part of dominant culture, and you've been excluded as a result of your identity group, means that you are experiencing a level of trauma, right? These adverse community environment. And so when we're talking about folks that are tough to work with or are tough to engage, who are Black and brown, you're talking to a person who is experiencing a level of ACE, right? Of adverse community environment, and who sort of like the next step of that is we need to be using a trauma-informed lens at every moment as we engage with those folks.
We also have this idea of intergenerational trauma. Right? So this is also something that folks are likely very familiar with. I like to say that helping professionals love a triangle, right? So there's another triangle here. And really on this image, we can see that all these awful things throughout our lifetime, right, contribute to like maybe an early death for folks, premature death. And I think that's really helpful for understanding all of the negative health outcomes that can be like leading up to that, right? So things like the higher and increased rates of blood pressure for Black and brown folks, disease, disability, and other social issues, and then those risky behaviors kind of being beneath that, all being reasons that somebody's life could end prematurely. But historical and intergenerational trauma is exactly what it sounds like, right? Trauma that is passed down through generations. This can occur through emotional responses of parents, which affect the coping skills and relationships for future generations, right? The folks that they're parenting and taking care of, as well as impact a child's brain development, including neurochemical changes that can also be packed on, right? So it's more than just like, oh, you had really awful parents and now you're a really awful person, right? It's like you had really awful or mean parents, and there are reasons for that, right? And we talk about those too, and those folks need care and support as well. But also, like, what physical impact has this had on your well-being, right? Yes. So that's intergenerational trauma here. I think we can move on for some room for change and what can we do?
Yeah. So I want to go through this quickly because we're not here to talk about how to change our whole systems, but but we put that slide earlier on like the colorblind system and the way that we sometimes perpetuate disparities among folks that we serve. And so I just want to kind of call out that the National Alliance to End Homelessness has put together a pretty cool toolkit that that allows us to kind of take a multi-layered approach to dealing with racial equity in our system. So at the policy level, they make some recommendations. They make some recommendations at the COC or like community level, and also some recommendations at the organizational level. There's things that we can do at each of these levels to kind of do what Ibram Kendi was suggesting, is to make each of our policies anti-racist, right? So yeah, I see a couple of folks asking me now for copies of slides or whatever. Yeah, we're going to send out a copy of the slides to everybody who's in this session. So you'll definitely get a copy of this. Okay, that's where I want to stop there with the systems change slide. We're not here to talk about systems change. We're here to talk about how do we engage tough folks. But we would be remiss not to share that, like, it's not just you, the provider, right? Your organization has some skin in the game, your community does, and all of us at the kind of national level have some skin in the game because it's a much larger issue than just interfacing with this one person. All right.
Okay, so this is a pretty popular image. Folks might be familiar with this already, or at least these first two images, right? Equality versus equity, right? We're all love and light about equality, and now the conversation is more centered around equity, right? And the way I like to describe equity and to kind of chip away at some toxic kind of workplace stuff for helping professionals is sometimes we might be like, why are we favoring this person, right? Or why are we doing this thing for this person? And the answer might actually be equity, right? What this Black trans person needs in terms of services and care is not going to be the same thing that a white person in our care needs. And that doesn't mean that this white person doesn't deserve care and support, right? But I'll give you an example. So I used to lead the polysubstance use team at Pathways, right? And we served two trans women of color, right, who we know are at an increased rate of violence and also death and murder in our community here, right? Pathways policy is to see folks bi-weekly, right, in their units for a home visit. But because of this data and this evidence that we know about these folks' increased likelihood of dying or being murdered, right? We might increase the amount of home visits we do with this person, right? And check in with them every week. And that is not favoritism, right? That is not us liking this person more. That is us adapting to what is the reality of this person's life and likelihood of community violence, right? So that is what equity might look like in the service context. But even further than that, in this image, we see reality is that folks aren't always starting at the same point, right? So the equity piece is everybody is brought up to kind of the same level. The reality piece is recognizing that not everybody starts there, right? And is going to need kind of different supports to be there. And even further is getting rid of that wall completely, right? Is liberation and really no need for us anymore, right? And our jobs and people being able to move around freely, access services as they need without stigma, oppression, discrimination, and the structural racism piece. The therapeutic alliance. This is, I think, a big concept and is an entire training in and of itself. But in a nutshell, it talks about the quality of interpersonal relationship between the client and the therapist, right? So things like trust, respect, genuine affection, and collaborative and purposeful work. This isn't your black and white therapist or your neutral therapist, right? There needs to be some form of relationship there to foster any sort of trust or collaboration for folks, especially because of things like structural racism and discrimination in other service settings before a client makes it to our space. I also want to be clear that you don't have to be a therapist to have therapeutic interactions with folks. You can be a case manager, you can be a peer specialist, your role can be whatever. You can still foster kind of safe and supportive interactions with folks. But the key components here are going to be to lower thresholds for folks, taking a neutral stance towards some things that maybe folks aren't typically very neutral about, right? Exploring kind of the negative experiences that folks are coming to us with, and collaboration, right? Making folks are as open as possible to the care that they are receiving.
Yeah, another kind of set of tools that we want to share. And unfortunately, there's whole trainings on this too. We don't have time to go in depth with each of these, but our next session, we are going to bring in more info about how do we tap into that therapeutic alliance, and then how do we make use of things like cultural humility and implicit bias. But in short, I want to say that an approach of cultural humility is going to be necessary for any person providing care. And we'll define cultural humility as the move toward maintaining an interpersonal stance that is other-oriented. In other words, open to the other, the experience of other, open to people who are not in your in-group, especially in relation to aspects of cultural identity that are most important to the client, right? And so I think we've long understood cultural competence to be, oh, I can learn as much as I can about another culture, another racial group, another minority group, and then I'll be ready to provide services to them. But that's just sort of taking stereotyping to its conclusion, right? And so what we want to do is cast aside the stereotypes and directly engage with what the person in front of you, how do they define their cultural identity and what's important to them, and how do they want to receive help. We mentioned already implicit bias, and so what we're kind of inviting people to do is find ways to uncover that. And I want to say that it's impossible to get rid of all of your implicit biases. But what we can do is hopefully we can slow down those biases enough so that we can tap into the values that are important to us, whether that be equality and equity or being a helper or whatever. Slow down the stuff that's getting in the way of that and align more closely with what we believe when we state it out loud, right? A component, here are the kind of pillars of cultural humility. It involves both institutional and individual accountability, and understanding what that accountability can look like in your context. It involves lifelong learning and critical self-reflection. You haven't ever reached an end point with cultural humility, unlike with cultural competence, right? So we're kind of always doing this self-assessment, this self-awareness work. Are there disparities in how I'm treating people? Am I noticing different outcomes? And kind of always asking us ourselves these questions in an ongoing way. And then finally, recognizing and challenging power imbalances. We started to tap into that in the chat a little bit, like where do you notice power imbalances? And the one cool one that came up was like different bathrooms for the providers and the participants, right? And some are clean and some are dirty. And so challenging that is a part of our role in fulfilling a cultural humility component there. And then the last thing I'll say is that one way we can tap into cultural humility is being open to cultural opportunities. And so this is a concept where there are certain moments that happen in an interaction with a participant where there's an opening. There's an opening to kind of really attend to a person's cultural identity. They've left you a breadcrumb about themselves. And we need to sort of, what I've been saying lately is like, go slow to go fast, right? To really develop that relationship, we have to sort of like toss our agenda for that meeting out the window and tap into that cultural opportunity, that moment that's important to them. And that's going to build relationship and actually help us help somebody else move toward healing faster, right? So take the time to do that work when it comes up, because that's going to be most impactful. Yeah.
So right off the back of cultural opportunities, one of the things we can do to combat this directly, or to at least bring it into the room, is to talk about it, right? If you work in harm reduction spaces, or with substance use or mental health at all, you are very used to and familiar with having these taboo discussions with folks, right? So the same can be applied to the idea of talking about race and culture for our folks, especially when it might be impacting the work that we're doing. And this also might be an ethical obligation that we have, right? To be talking about this from the front, to be able to provide the best care that we can, to help folks feel safe and supported. One of the things we need to also do through an ethics lens is acknowledge that we're not colorblind and we don't treat everybody the same. If you've ever interacted with the folks who say, I treat everybody the same, has that been true to your experience? Do you feel like that person has treated you the same that they've treated every other single person in their life, right? Probably not. So this is something we really need to kind of work toward eliminating. And if we are treating everybody the same, we probably shouldn't be, because we know that folks have different needs. Cultural background and the information we have about clients does impact the way we provide care. And that's also something we need to be aware of, so that it's not influencing any sort of treatment decisions in a way that might chase this person away from care in the future. And we also don't want to maintain this neutrality, right? I'll give an example that's not specific to race, but I will remove race back in. We don't like to have conversations we're uncomfortable with, and that makes sense, right? If you are a harm reduction provider, you might be a little closer to this goal and being able to not be neutral, right? I used to do intakes with folks in the therapy space, and because of my own stuff and the ways like suicide has touched my own life, I would ask I'd ask the normal suicidal questions, right? But also be nodding my head no, right? Any history of suicide, no, right? And just be like soliciting this response, a response I want to hear and that made me comfortable as a provider, right? Which sustains that stigma, right? That if I have ever felt this way in my life, it's not welcome here in this space, or that you can't talk about it, or something's wrong with you if you have had this experience, right? And in the same way, we don't want to be neutral about when people are coming to us with like racist experiences. Oh, you used to have a racist therapist, or a therapist who said this thing that you felt was a microaggression. We don't have to talk about that. I treat everybody the same, right? Is not a way we want to be interacting with folks. That is a cultural opportunity. When someone is coming to you and saying, I had this really terrible experience in this healthcare facility and I felt like I was being discriminated against, or I felt like my provider was racist, we need to hold on to that and talk about how this experience and navigating care here with you, a new provider, or an agency is going to look a little different, right? And foster some sort of safety that is different than what they've come from. And to wrap this up a little bit, we have a fun quote, right? When you are living and working in harm reduction work, it can kind of feel defeating to always be heard that you're enabling these negative behaviors, right? So I think this quote really speaks to kind of the structural piece. And like, yes, we are supporting our folks' right and will to live, right? But also combating some structural factors that are impacting our folks directly. So this quote is from Daniel Raymond from the Harm Reduction Coalition and says, I got into harm reduction to enable people who use drugs. I enable them to protect themselves and their communities from HIV and hepatitis C and overdose. I enable them to feel like they have someone to talk to, someone who cares, someone who respects them and their humanity. I enable them to ask for help and to help others in turn. I enable them to find drug treatment and healthcare, to reconnect with their families, and to rebuild their lives. And I enable people who use drugs to take personal responsibility for their health and their futures. If that makes me an enabler, I'm proud to claim that term. That's just a little bit of encouragement, a cool quote for the harm reduction work that folks might be doing in your own spaces to kind of combat. This is an example of what we can be doing and how we can be framing our work to kind of chip away at some of the structural barriers our folks are experiencing on a regular basis.
Amazing. Thank you. Okay, I have 2 slides left. I recognize folks are needing to probably get on to other meetings or head to the next part of their day. So I just wanted to say I have 2 slides left. If you're able to stay to the end, let me bring it home for you. So the first thing I want to say is assertive engagement is the kind of one of the solutions that we want to bring to the table, both here at the end and also in our next session, right? And so assertive engagement, really quick definition, is the process where we're using our interpersonal skills and our creativity to make the environments and circumstances that are crappy, that people have been living in, more conducive to change, right? And so we're bringing all of that interpersonal skill and creativity and relationality and cultural opportunities and therapeutic alliance to kind of shift the environment of the circumstances in some way to help shake something loose for change for folks. We're also trying, to kind of ask this question, what more do I need to do with my client to get some contact with them and to make it valuable, right? You might only have one shot. How do we make that time as long as possible and valuable? And then ultimately, we want this work to be non-coercive. And I'll say, this is really important to us here at Pathways. It's part of the Housing First Fidelity Principles. One of the Fidelity Principles says the program does not engage in coercive activities to promote engagement or treatment adherences among participants. And we know already through our discussion of power dynamics that coercion is not going to be an effective tool in building a therapeutic rapport, right? And so anything that we do, any strategy that we use has to be non-coercive. Otherwise, we're shooting ourselves in the foot. Okay, so I'm plugging the Assertive Engagement training next week. It's called Assertive Engagement, Tapping into the Therapeutic Alliance. I'm sorry, not next week. September 26th, same time, 1 o'clock. I'm trying to rush. I know you got to go. Last slide. Here's my takeaways. We are coming into contact with folks who are in tough environments, are in tough circumstances that are not necessarily conducive to change or to engagement at all. And so we have to get rid of our business as usual, right? It's not going to be enough to engage folks who have been left behind by the current systems or following rigid program rules and structures or making sure that we're enforcing power dynamics. This will not be the way that we engage people who have been the recipients of structural violence and trauma. The tools that we're wanting to kind of leave you with are cultural humility, harm reduction, and assertive engagement, among many others. Okay, that's it. That's what we have for you. I personally have a few minutes I can hang on the line for if there are like specific questions that people have. But if you have to run, thank you so much for being here. We've really appreciated the dialogue and your engagement in the session. And I have put the course eval link in the chat. Please complete that course eval, give us some feedback, and look out for our materials via email a little later today. Thank you so much.
Nice talking to you all. Take care.